Right. This is the fourth of a series of 4 webinars. We've been looking at case studies from Japan, Denmark, the Netherlands, and we're looking at France today. And what we're trying to do here is to see what the English social care sector can learn from the COVID-19 experience of the long-term care systems of other countries. I'm going to share a bit with you the methodology and how we've got to this stage of the case study. And then we'll hear from Camille Oung, Alice Sopadzhiyan, and Blanche Bihan on what lessons the English social care sector could potentially be learning from the COVID experience. So just to introduce the project, this is funded by the National Institute of Health and Care Research. And the aim of the study was to draw lessons for policy and practice from the international COVID-19 experience and from scientific evidence to support the social care sector in recovering from COVID-19 in the short term and to be better able to withstand future waves of COVID-19, similar shocks in the medium term, and to become more resilient in the longer term. And the way we've set about doing this has been, first of all, to do a very deep situational analysis of the English social care COVID experience. We've also engaged with stakeholders in various ways, including a theory of change workshop. And this has helped us identify priority topics and areas where evidence is needed. And from that, we've gone on to identify topics where we wanted to go more in depth in terms of evidence reviews, but also 4 countries where we thought there were relevant lessons for the English social care sector to learn. And to choose these 4 countries, we drew on accounts from international experience from the LTC COVID initiative. We've then worked on these 4 case studies, and as I said, I'm delighted to introduce the 4th one today on France. And the next step for us will be to work with stakeholders to co-develop policy and practice recommendations that would be relevant to the social care sector in England. And just to put a bit more our thoughts on how this learning process can work. First of all, we should stress that it's very difficult to compare how long-term care systems performed in the pandemic. This is because before the pandemic, we didn't really have metrics for international comparisons. And also because even during the pandemic, the data that we had was very poor and was collected in different ways in different countries. Even what could potentially seem simple, like, for example, counting how many people died linked to COVID in the pandemic, was actually very difficult to do in practice. We also know that there could be potentially data or analysis on what was the quality of care and support that people received or the impacts of well-being. But because of the way the studies have been done and data is collected, we can't really just go and say, oh, this country did better than others. But what we did, and Natasha will talk a bit more about that in a minute, was to look in detail at experiences and the mechanisms that were behind those. To also give a bit more context on the impacts of the pandemic in these 4 or 5 countries that we're considering, these have been very different. The last webinar we heard from Japan, where for the beginning of the pandemic, the population was very well protected from COVID, and that was a very different experience than what was happening in many European countries, including the UK and France, where there was quite a rapid impact very early on, and there have been very big number of deaths in the total population. And in terms of the population in care homes, where we do have some data, what we found was that there was a very clear correlation between the impact of the pandemic on people in care homes and the impact of the pandemic on the population living outside care homes. And that's telling us that what really seemed to make a very big difference was how much COVID was spreading in the community, and that although the measures were adopted were important, their impact was always going to be quite difficult, because it seems like whenever you have this virus running wild in the community, it will find its way into care homes as well. So I'm going to hand over to Natasha to tell you a bit more about what we learned from looking at the English social care sector.
Thanks, Adelina. So as Adelina just set out, the way we started this project was to try to understand what factors influence the response in social care in the English social care system. And we've used that as a lens to collect up priorities that we think need to be addressed if we are to create a more resilient system in future that's better able to withstand shocks. And we've used those priorities to then identify countries where there is potentially some transferable learning. So we're hopefully going to be publishing our report on England very soon, but just to give you a flavour of the sorts of things that we've identified. So we've grouped our sets of priorities into 3 broad groups. So when we were talking to people and collecting documents, what came through very strongly was that one factor that influenced the response and the effectiveness of it was this the complexity of the social care system and the fact that it's quite a complex set of accountabilities and relationships. And when it came to the response, there was a lack of clarity about who was responsible for which bit of the response. Was it national government, which department, was it local government, was it providers, was it the NHS? And we think that slowed down some of the response. We also think there were some opportunities missed in the years running up to COVID to prepare the sector, and we think that that should be prioritised going forward to make sure that the sector is more prepared for a similar shock. Then we identified a number of factors around what we call the people, but social care is a hugely complex and diverse sector, serving and supporting people with very, very complex and diverse needs. And at times in the early part of the response, the guidance was not always tailored sufficiently to that diversity of need, which obviously impacted on the experience that those people had in those early months. There was a key factor around the workforce as well. When COVID hit, the workforce was under severe pressure. We had high vacancies, high turnover, and it was already a stretched workforce when COVID hit. One of the very key things that we picked up was not just the numbers and the vacancies, but also the structure of the workforce, and the fact that about a quarter of care staff are on 0 hours contracts and didn't have regular access to sick pay, which obviously impacted on policies around isolation and sickness. So we think that leads to us to a recommendation around a need for a more robust workforce strategy that addresses some of those issues. And then the final bucket of sort of factors that we identified is around resourcing. So if you look back over the decade leading up to COVID, there was a tendency to fund social care through short-term injections of cash, which hasn't really facilitated huge investment in the infrastructure. And so a lot of the care homes who were dealing with infected residents were not modernised, didn't have en-suite facilities, and they found it really difficult to isolate and cohort people. So I think there's a lesson there around how we future-proof our infrastructure. So that's a flavour of the sorts of priorities that we identified. Could you go to the next slide, please, Adelina? And then we took those groups of priorities and we did a high-level mapping across the world to see which countries had maybe a similar experience or had some potential positive learning that we could draw on. And then we identified the 4 countries that we've decided to focus on. And as Adelina said, we've had 3 webinars already on the Netherlands, Denmark and Japan. And today we're going to hear about France. And I'm going to hand over to my colleague Camille, who's been leading this with colleagues in France.
Thanks very much, Camille. Natasha. I'm just going to share my slides. Can everybody see that okay?
Yes. That's great, yes.
Fantastic, thanks very much. So yes, I'm Camille Oung, I'm a researcher at the Nuffield Trust and delighted to be here as well today with colleagues in France, so Sopadzhiyan and Blanche Bihan. So why France? So Natasha touched a little bit on this already, but I think France, like England, was facing some similar challenges to England going into the pandemic, but also did have some very distinctive features which helped as well the pandemic response to an extent. And France has also chosen to address reform during and after COVID in a different way to England, so focusing on different aspects of reform. So I think we have a very interesting comparator here around how different approaches have played out. So kind of our key lines of inquiry have been around the level of preparedness that France had going into COVID and what COVID revealed about whether those preparedness plans were sufficient, what could be improved. We also chose to focus a lot on the workforce, so looking at how France's approach to supporting the workforce has been successful or not on helping the ability of the sector to respond to COVID and maintain services, how those workforce issues have now been addressed and whether they've been kind of successful in helping the sector to maintain stability and sustainability. And then finally, France, like England, has engaged in a reform programme over COVID, and one thing that we've been very interested to see is whether those reforms have learnt from the COVID experience and whether they go far enough in addressing issues in the social care system and where that kind of brings the system to now. So a brief commentary kind of on the system going into COVID. So France's main policy for older people, and I think I will focus largely on older people today, but I think colleagues can comment on working age adults if necessary. But the main policy for older people is a cash for care scheme for people over 60 who have care needs above a defined threshold. And there were a number of issues going into COVID with the social care system. So firstly, reform was long overdue. A number of reforms had been tabled, but the implementation of them had been incomplete. There had been debates over more than 20 years about how to address the funding of the system to ensure that the system could be on a sustainable footing. And so, for example, plans to revalue debt had been tabled to enable the funding of reforms, but these had been kind of derailed with competing priorities such as the Yellow Jacket movement. So I think the implementation of reforms were really in competition with lots of other priorities as well, and had meant that they hadn't really been successfully implemented. The system in France is very complex, so there are some complex arrangements around financing, which means that there isn't really a full picture of a unified social care system, and this has also led to challenges in access. So there are two kind of key local actors which have accountabilities in social care, so the local authorities or département and the regional health authorities who both have a role in financing aspects of social care. So for instance, in residential and nursing homes, local authorities kind of fund the social care part of things, but regional health authorities fund the nursing side of things. And so whereas domiciliary care is exclusively within the remit of local authorities, and this creates a very complex and fragmented landscape. The system is also difficult in terms of access, and lots of people have to pay high levels of out-of-pocket payments as well. Again, a similar challenge that we see in England is around the workforce, and these issues were well evidenced going into COVID. There were issues around low satisfaction, poor working conditions and pay, and also evidenced by things like comparatively high employment rates and sickness rates. And this has kind of impacted on the level of vacancies, retention issues, and enabling or making difficult the provision of care, with lots of care providers being under strain. And another consequence of that is largely providers being under strain. So I think possibly comparatively to England, there is a high proportion, I think, of people who receive care in residential and nursing homes and not necessarily leading then to positive outcomes. I think the infrastructure around residential nursing care is known to be quite outdated. So for instance, with things like shared bathrooms and kind of quite old stock, and also with limited drivers of quality and improvement. So a lesser role for regulators like we might have in England with CQC. So this meant that the impact of COVID in France, and in particular in social care, was quite stark. So research done by colleagues in France has shown that 3/4 of residential and nursing homes had at least one resident infected by COVID-19. 1 in 5 homes experienced a critical incident in which more than 10 residents, or 10% of the total number of residents, had died, sadly. More than 29,000 people sadly passed away in care and nursing homes, and a very small number of health and social care professionals were also affected by COVID and died. So COVID, I think, really exacerbated and brought to the fore some of the structural issues that the French social care sector was facing going into COVID. So firstly, around the very complex governance arrangements that I was describing. So I think because of this complexity of how different actors played or had accountability in social care at a local level, it meant that the social care sector wasn't very visible at a national level. And I think it really hampered that response, and it was very slow to kick in around social care. And so, as one Carers Association put it, the crisis was seen as a crisis in hospitals when really it was a crisis of the home, and a lot of the guidance and support was quite delayed. And I think some of the challenges with this accountability meant that it wasn't really clear who was in charge at a local level. And in particular, local authorities had a very varied response across the country. I don't think we've necessarily heard, we've spoken to a few local authorities who've had very different perspectives on their role, but I think potentially with the variability in the skills that they had, the knowledge that they had, it made it a lot more difficult for them to support the providers, in particular domiciliary care providers. And this kind of lack of knowledge and understanding of what social care was at a national level meant that some of the policies were quite restrictive. So in particular around visiting and care in nursing homes, there was a very ageist approach. We've heard that quite a lot from the people we've spoken to. So for instance, there was a proposal tabled around unlocking by different ages. And I think that was really perceived as highlighting a lack of understanding of what good outcomes are for older people. Likewise to England, workforce difficulties were very much exacerbated by COVID as well. So there was high turnover, difficulties in recruiting, and also insufficient prioritisation given to the staffing needs of social care in the national government COVID response. So one example being, for example, in the early months of COVID, permission slips were needed to go outside. And domiciliary care staff, I don't think were considered as key workers, and so weren't granted permission slips, and were often in the early months at odds with the police or whoever might have stopped them to question why they're outside when they were just going about their work. I think it is also important to recognise some really good positives that did help to mitigate some of the impact of COVID. So nationally and across a variety of sectors, there was this whatever it takes policy, which helped to maintain stability. So there was a national drive to maintain funding to care providers. So this meant that providers were kind of funded for their placements regardless of the level of occupancy or the level of need, and it meant that providers were able to take things in a much more collaborative approach rather than a competitive one. There were also some preparedness plans in place, which I'll come to in more detail in a second, and I think the perspectives on these were a bit varied, but I think overall did help to have some level of a foot on which to stand for care and nursing homes in particular. And there was also, through the local flexibility, improved collaborative working, so greater collaborative working across local actors, greater involvement in care managers in kind of the response, and also the development of the role and importance of things like integrated networks, and also the role of federations, who were really key in distilling information at a national level to providers, and very much grounded in social care at a local level. So I'll turn now to kind of some of the lessons which we think are really useful for the English context. So firstly, I mentioned the existence of these blue plans, which were put in place in care and nursing settings following a heat wave, which had very detrimental consequences in 2003. And these plans were intended to help managers to plan for crises, so not just limited to outbreaks of infectious disease, but also to consider things like terrorist attacks or climate change. And the idea was to get managers to think about what key resources would be needed and within a situation of crisis. So for example, which resources around PPE, what staff numbers were needed, how to ensure continuity of food provision, and also to have this level of continuity among managerial staff should there be turnover. And I think overall these were useful documents, but to many people that we spoke to, they were also considered to be quite administrative, quite bureaucratic. And so many care managers had seen these as quite a box ticking exercise that were largely out of date in a lot of settings, and also perhaps lacking the flexibility to react to the very rapidly changing nature of COVID. And another point that was highlighted to us is that it's one thing to be able to quantify what you might need in terms of resources, but if then national actors or local actors aren't able to meet those resources, then the plans don't kind of have their full utility. So for example, you might be able to go to a local authority and say that you needed PPE, but then the local authority not be able to provide you with that stock. So there were some challenges, and I think there is some sense of learning now, and I think the blue plans have been adapted following COVID, but it will be interesting to see whether they kind of stand the test of time. So I think for England, some of that key learning is around, there is a benefit to strengthening preparedness, for example, through more robust planning documents. But what we heard as a really positive example of how France has also learned from this is that care managers are also receiving training around crisis management, which was something that happened in other settings like the acute sector previously. This kind of strengthening the overall level of preparedness. So a second lesson to focus on, and we've touched on this a little bit already, is this clarity of accountability, and the fact this complex web of actors at a local level and this shared ownership between regional health authorities and local authorities really created a lack of ownership during the pandemic. And with the kind of lack of visibility at a national level, many individual providers were left having to try and navigate this complexity alone, and were left with the responsibility for decision making without necessarily having the right skills, the right information to be able to make those decisions, and were kind of left to interpret that in their own setting without necessarily knowing if that was the right thing to do. And I think an interesting point that was raised to us is that regional health authorities are kind of local representatives of the state, and often were reluctant to commit to giving answers without having a directive from the national level. And so there was kind of fear that you couldn't really say anything without it being accepted from the national or said by the national, and sometimes just meant that there was an absence of answers to really key questions. And I think that kind of lack of clarity over who was responsible for different parts of the system is still a feature of the French system, and is really jeopardizing current plans for reform. And I'll come to this in a bit more detail in a minute, but I think it's still not really clear who should have a key ownership between these two kind of competing actors over social care. And so I think what we might want to take away for England is both that, there is a role for national government in clarifying that accountability, but also that, without that accountability being clear at a local level, you can really be impacted in terms of how reactive you can be, and hindering kind of long-term opportunities for reform. And the kind of knock-on from this complexity of accountability is around the domiciliary care sector in particular. And I think because domiciliary care is largely in the remit of local authorities, it really was very much invisible during the early months of the COVID response. I think, and both decision makers at the national level and at the regional level didn't really have an understanding of domiciliary care, how many providers there were, what the makeup of needs were within domiciliary care provision. And so there really wasn't very much prioritization of domiciliary care in the same way that healthcare or even other parts of the social care sector had. And so, as one stakeholder put it, the home care system really crumbled because there really isn't a system. And I think in plans for reform, there have been ambitions to take a more of a home first approach, but not necessarily met with adequate funding, or a lot of the investment has gone into residential and nursing care. So it's not really clear that even post-COVID, recognizing the huge impact that COVID had in domiciliary care, that kind of learning has been taken on board. And I think, given the kind of changing and growing complexity of need and the ambition to deliver more care in the community, I think that we really do need to recognise, both in France and in England, that really strong value and importance of domiciliary care as that backbone of the system, and it needs to be prioritised and valued accordingly in plans for reform. A fourth lesson is around the value of the workforce, and I think this is a really key area of learning, especially given some of the challenges that we are seeing both in France and in England around the recruitment and the retention of staff in the sector. So something that's quite interesting that happened in France is that there was a sector-wide reform introduced in the summer of 2020. So this was both across health and social care sectors, and there was a commitment to increasing pay rates across the sector as a recognition of the contributions of staff over COVID. And this was initially viewed as very positive, valuing of staff with lots of positive recognition of that contribution. But the way that the policy was implemented led to quite a lot of unintended consequences. So the salary increases were first rolled out to staff in the acute care sector, then rolled out to the wider health sector, and then only through kind of some level of negotiation to staff in public residential and nursing care homes, and through quite intensive negotiation with trade unions and collaborative wage agreements, that these increases were also moved on to domiciliary care staff and also in the independent sector. And this kind of patchwork way of rolling out the reforms, where it was announced for the entire sector but actually kind of intended largely for the acute sector, kind of actually really exacerbated that feeling of staff in social care, and in particular in domiciliary care, not being valued. And so it had that kind of flip effect of now a lot of staff in domiciliary care have left the sector because, you know, they don't feel like they have been recognised for the work that they do. And I think one interesting piece of learning, I think, for England is that while I think salary increases do have a positive benefit on workforce recognition, first of all, these increases were quite small comparatively. There's now cost of living challenges, so they're comparatively not that high, but also in the absence of wider improvements to the sector, to the terms and conditions, to better opportunities for career development, there isn't really that opportunity to build a much stronger narrative of valuing the profession that can have a meaningful impact. And finally, before I move on to colleagues in France to talk to us about where the sector is at now, I think bringing us a bit more to the current period, I think ongoing reforms haven't really learned enough maybe from the pandemic experience. So there have been a number of reforms that have been undertaken since COVID, and I think it has been an opportunity to accelerate some of these. But I think largely there's been a feeling of disappointment from the sector because they've been kind of taken in a very piecemeal approach. So small improvements to introducing tariffs in domiciliary care, investments into improving the care and nursing home infrastructure, modernising, building stock, investing in things like innovation, technology to improve kind of outcomes. Another really key element of reform has been around the consolidation of the fifth branch of social security. So social care has been symbolically recognised as important alongside other pillars of the welfare system, so alongside health, alongside employment, etc. So really a key recognition of the importance of social care. But I think without addressing some of the questions of, who is accountable for social care, how does the system come together as a whole, I think stakeholders have really seen this as a sticking plaster and not really as an opportunity to learn from the experience of COVID as an opportunity to reform the sector more extensively. And so I think there was a general feeling that you need to address all of the parts of the social care sector if the system is to be put on a more resilient and sustainable footing that can truly kind of addresses the challenges in the social care sector, both short and long term. So I'm now going to hand over to colleagues in France, so Alice Sopadzhiyan and Blanche for their kind of feedback on what we've just presented, their thoughts on where France is currently and what learning England can take kind of from the pandemic experience in France. Thank you.
Thank you, Camille. So we were asked to identify a little bit the challenges that France faces currently. And I think that what you must have in mind concerning the pandemic and social care sector in France is that just before the COVID-19 a reform had already been announced. We had a report which was produced in March 2019 and which announced an important reform with a law on autonomy and old age. And when the crisis occurred in 2020, of course, the reform had not been implemented and the law had not been produced. So we are still waiting for this law, this autonomy and old age law, which has been announced in 2019. But of course, the crisis has had an impact because all the problems that had been identified within the pandemic, in fact, already existed before. And the report, which was produced before in 2019, pointed out all these difficulties that were highlighted and experienced during the crisis. So this is an important point. So though we are still waiting for a global reform, there has been some important measures which have been decided. So we will mainly focus on two of them. In fact, one of them and the other one are coming with this important one, which is the creation of a 5th social security branch in France, which was decided in August 2020. So within the pandemic time, in fact. But the decision was taken and the law was voted of the creation of this 5th branch of social security. And it is a main event and a main challenge to reform the social care policy towards elderly people in France. Now, this law constitutes a real switch to the approach of the autonomy policy, creating a switch at 2 levels. First, it creates a single autonomy sector, gathering disability and old age, which in France, in other countries, are separated and distinct. So it wants to create this global and unique sector of autonomy. And secondly, it includes the issue of autonomy in the social security system. So these are 2 important points which had been announced in 2019 and which were in fact implemented in 2020 during the pandemic. And the idea is now to have a new social risk, which is autonomy, and which concern both person with disability and old age. It's the 2 sectors. And so the social care dimension of the support provided to elderly people is now part of the French social security system, just as healthcare is part of the social security system. And this was not the case before. So this branch is managed by what we call the Caisse nationale de solidarité pour l'autonomie, which is the National Solidarity Fund for Autonomy, and which already existed since 2004. And there has been a specific agreement on targets and management, which was signed for 5 years and which which identify different objectives of this creation of a 5th social security branch. Now, concretely, in 2022, the National Solidarity Fund for Autonomy has a budget of 35.4 billion euros, which is an amount of money, of course, yet this does not mean the end of the debate. Indeed, the financing of the autonomy branch includes various types of funding aimed at people with disabilities and elderly people. And these fundings already existed, but it gathered the different fundings that already existed and which were formerly managed by other branches of social security system. So although this reorganization is a positive dimension, of course, because it gives more visibility and it's clearer for everyone, it remains insufficient for to face the coming demographic challenges. So concretely again, and this is important, it's not only financing, it's also the reorganization of the sector, and we have the creation of a territorial public service for autonomy, which has been proposed, aiming at developing better coordination between what we call in France social sector, medical social sector, and healthcare sector. Alice will tell you more about this.
So yeah, about the coordination and integration of the system, maybe again, just to mention what existed before the COVID crisis. And the most recent coordination policy in France was the creation in 2019 of a dedicated coordination scheme, which is currently under implementation. Those dedicated coordination schemes that Camille Oung talked about in her presentation and that she called integrated networks. So we are talking about the same thing, the same scheme. The aim about the creation of those integrated care networks was to address the great diversity of the specific coordination schemes in the elderly care sector that were created over time, over the past 20 years. And this diversity created complexity again. We started to talk about the coordination of coordination schemes. And so this contributed to highlight the need to better articulate the existing coordination schemes between them. So the government decided prior to the COVID crisis in 2019 to merge all the specific coordination schemes from the elderly care sector into one and single coordination scheme, dedicated coordination scheme, the integrated networks, in order to address this complexity and to simplify the coordination responses. Moreover, this new coordination scheme is now targeted to all users in complex situations, independently from their age. So this policy shows the government's will prior the COVID crisis to simplify existing coordination responses by proposing a coordination service, public coordination service for all users, and not only for elderly people. Then the intention now to create a new territorial public service for autonomy that Blanche talked about, and that was recommended in a report from 2022, goes in the same direction as the prior reforms and as the reforms prior the COVID crisis. And this, in fact, is a public service for coordination at the local level, as its aims are to better coordinate the public authorities, so the regional health agencies and the local authorities, and their responses in terms of coordination and supply policies. That means this public service addresses directly this complex governance arrangements Camille talked about. And its aims are also to coordinate the responses between the providers from the social care sector and from the healthcare sector. So these recent coordination policies, as well as the creation of the 5th social security branch, shows a very clear trend in France in favor of more regulatory power for the central state and its representatives at the local level, which are the health regional agencies. Without, in a context where those who have the responsibility for long-term care policies are the local authorities. So this is an important issue. However, these remain small steps policies as far as the governance of the system is concerned. They do not directly put into question the distribution of the roles between the regional health agencies and the local authorities. And also, as far as the simplification objective is concerned, the government continues to create other specific coordination schemes in other sectors, like in primary care, in mental health care, also in the disability care sector, which is now a part of the autonomy sector with the elderly care sector, which creates a new diversity that can be analyzed and somehow contradictory to this simplification objective of the recent reforms.
That's really helpful. I might pick up a question in the chat if that's okay. I don't know if the person who put this comment in would like to come in and say it themselves. If not, I can pick it up. But largely, I think the question, so there's a couple of questions, but the first being on kind of the political aspect to government and the kind of local social care function, and whether that kind of strong political role that we might see in local authorities in England is also the same in France, and whether that also creates some of the some challenge, I think, to coordination opportunities.
About the local authorities?
Yes. Yeah.
Okay, so it is this historical separation between responsibilities between the local authorities ever since the 80s and the regional health agencies from the beginning of the 2010s is really a historical issue that is very, very difficult and a very political issue, and it is difficult to address by the central government. There have been several waves of decentralization policies. There have been 3 different waves of decentralization policies, and the last wave of decentralization policies does not give, is the first one that did not give new priorities to local authorities, and it gave new competences to other local actors that are either smaller territorial areas or bigger, such as the regional health agencies, for instance. And in the during the period where the law about this third decentralization act was discussed, there was also this idea of putting away local authorities from the governance of the sector. This did not happen. It was just not possible to happen, as local authorities are a very strong political actor. So what we see now is that local authorities are still there and they continue to do their job. But these small steps reforms that does the central government, like the fifth risk, like this public territorial service for coordination, are small steps that go in the direction of obliging local authorities and regional health agencies to cooperate. I mean, now they have to cooperate in theory. All the acts, different acts and laws say they need to work together, but concretely there is no obligation to do so. So this goes in this this direction to make them work together, and they are obliged to do so. And we can suggest that maybe at the long term, in 20 years, all these different small steps would have done something about this switch in the responsibilities between the local actors, which clearly, right now, from my point of view, is not very, it goes towards more power to the regional health agencies.
Mm-hmm.
And just to complete and maybe try and start to answer José Luis Fernandez's question about the top-down social security system, the consequence, what does it mean, a fifth social security system? Because of course we think about the social security system as it exists, but in practice, the fifth social security risk and the fifth social security branch autonomy doesn't work as the other. It is not, it has the name, it has the ambition, but of course you cannot reform the system and go from a bottom-up approach to a top-down approach. So it is a specific risk, and the management is specific. As Alice says, the local authorities are still here, are still there. And for instance, concerning the funding, because of course I think that it's great to have on the paper this fifth risk of autonomy with disability and old age together, but now in practice it's not done yet. And concretely, if you think of the funding, we still have 65% of the funding of the APA, the allowance for old age people, elderly people, which is funded by the département, so by local funding. So, which means that the flexibility still exists because we still have a management in proximity with the families, with the care users, with the recipients of the allowance. So this is why, I mean, we as researchers and analysts of this issue since a lot of time, as you know, we are really waiting for concretely what does it mean. And it is true that there has been this agreement with objectives, but I've read the agreement and I think it's a bit general words for the moment. It's just the idea of simplification, administrative simplification, meet the needs of people, domiciliary care, which is important, all that Camille has underlined. But concretely in terms of funding, we're in the same position. We have the budget of Social Security, which already existed, but it was in the healthcare system. It was in other parts of the Social Security system. Now it's gathered in one, which is really a good idea, of course, in terms of clarity. And we still have the local authorities which fund part of the allowance, for example. But the good point is that we don't have, on the one hand, the healthcare system, and on the other hand, the social care system. It's going to have to be thought together because of the social security system. So in terms of symbolic approach, I think it can have real impact in the practice, but we have, as Alice says, we have to wait. It's the beginning of something, hopefully. It's the beginning of something in terms of thinking the issue of elderly care in terms of social security. It's not the same as before. So for sure, it's different. Another problem is that of the unique sector of autonomy linking disability and old age. I think that's another issue, which is complex too. So wait and see, and I'm eager to see what will happen in the following years, and we keep in touch anyway, José Luis, to tell you what the story is.
Sounds good.
Can I add something?
Go ahead, Alice.
So we have this top-down, well, central regulatory power, and you've understood that there are things that are happening, and we still have those local institutional actors that are the health authorities and the local authorities. And another trend maybe to add is the accent that is put in all the recent acts and pieces of law at the very local level, and at the flexibility that is needed for very local, I mean, concretely providers to respond to disabled people and elderly people, to their needs, to their complex needs, which is good because we've seen with the management of the COVID crisis that more freedom was given to local actors, and there were very good pieces of innovation about local organizations, so on and so forth, and coordination with the community actors, also not only health and social care actors, but risk. As a political scientist and as a researcher, I would say the risk is that on the one hand, we have this objective of making local actors respond to local needs, but in an absence, but there is no overall reform and financing for this overall reform. So what are going to be the means of local actors to respond to these needs? This is what we're concerned when we analyze those trends.
It's a really useful point, and I think will sound very pertinent to colleagues in England. We've only got 10 minutes left. I don't know if there are any other questions from the audience. If not, I was quite interested about the question of professional development among social care staff. And I think especially this challenge of strengthening that professional perception. Would you have any comments on that, or thoughts on how the implementation of things like the Ségur has had on the stability of the sector?
Yeah, I will have a comment, because I think it's important when we do comparison. This is what is great in comparing situations in different countries, because when we're focused on France, we really underline the fact that the professional care sector doesn't exist. It's weak. We have many problems. The care workers have precarious conditions.
Mhm.
Yes, this is of course true. But when we compare, we French people must have in mind that, of course, there are problems and they are important. And the COVID-19 has shown that we must increase the number of care workers, social care workers in institutions. We must organize and think about a domiciliary care sector. So this is true. And there has been an increase of the number of care workers announced. More recruitment will be possible in institutions. And there has been also the Ségur and the increase of the salary. And it's insufficient. It's true too, because we don't have this global reform to think about what the professional care sector could be. Yet in France, you must have in mind that there has been some measures which have been taken since many, many years. And for instance, qualification is possible for care workers. They have, just as nurses which have a qualification, there is also the possibility for social care workers to obtain a specific diploma. And this since 2002. So it means that with the creation of the long-term care policy in France at the end of the 90s, there has been also a strong wish to structure a professional sector of social care work. It's insufficient, but things already exist, and we have possibilities of qualifications, and there are social care workers who are qualified care workers at home, not only in institution, also in domiciliary care. So this is important to have in mind. Also concerning the working conditions, yes, it's insufficient, the salary are insufficient, and this is true. Its precariousness is important, but since many years now, the social care workers, home-based care social care workers who work at home with the elderly people have a flat rate salary and contract, which means that they are not only dependent on the number of elderly people they work with. And, when one old people die, when you lose part of your wage. In France, there is this possibility to have, as social care worker, a contract and a flat rate wage each month. So it's insufficient, but it exists.
That's really useful. Remind me how so qualifications are mandatory to work in social care?
No,
They're
no.
not mandatory.
Mandatory for nursing, for nurses, but not for personal carers or social care workers. And this is the problem, because you have, in fact, an important variety of profiles of social care workers. Some have the qualification, and when they talk, they present themselves as qualified professional. When we do interviews with them, we have done studies on care workers. They present themselves as professional, and on the other hand, you have people who have no qualification and just consider themselves as domestic cleaners. So the variety of profiles is important.
Adelina, did you want to come in with your question so that we have time to address it?
Yeah, I think you mentioned something to me about changes in the regulation or the standards for care homes since the pandemic, and it's something we're seeing bits of in different countries. And just wonder if you could say more, or whether maybe I misunderstood.
Well, about changing standard. Well, you're going to complete because you did research on care homes. But there are two things maybe that we need to mention. The first thing is what Camille talked about is the Ségur de la Santé, which is a specific measure to the care sector, health and social care sector, including care homes. with specific dedicated funds for the professionals, for their professional recognitions, and for their formation, training, and for their training. There are also specific measures about the standard, renovation of care homes that appeared to be obsolete during the crisis. And for instance, with no access to the outside, or with no access to a personal bathroom. So this Ségur de la Santé, which are specific fundings, again, it is not how to say,
a global reform or reorganization of the sector, or structuration of the sector.
Yes. These are very specific fundings about the care home sector that exists, that are under implementation, and that are going to have good, some effects about the service standards,
and which are appreciated by the
which are appreciated.
Yet,
but we should maybe mention something else that happened during the crisis, and that is not related to COVID. This was the publication of a book about a very big scandal about the way some private care homes managed their care staff and also their users, the residents, the people that were in the care homes, putting into light very big
quality failures, I think.
yeah,
exactly.
Yes,
like not giving elderly people food, for instance. Things like this, and this have had a very big impact at the all the public media talked about this.
Mm-hmm.
So there were also specific measures about this, mainly about training more inspectors of social and health affairs from the ministry that we train here at the French School of Public Health, so that they can go and do more regular controls about the way public funding is used in those care homes. And maybe this has also had as an effect some kind of public awareness, but this is also true about the COVID crisis, about things that may happen and the conditions in which they happen in care homes. Maybe some public awareness about the need to have care homes, quality care homes, and that meet elderly people needs, and that respect them as citizens and as a part of the society.
Yeah, and this is a bit confusing, because this scandal, which concern in fact private, as you know, in France we have private nursing homes, full profit, private, and we have public, and in the middle we have non-profit organizations, non-profit nursing homes, which we really assimilate to public residential care. And these private for-profit nursing homes, which are really pointed in the book and in the publication, they concern, of course, not a lot of nursing homes, it's only private, and but it's very confusing, because on the other hand, there is problem in the other non-profit and public residential care homes, with the insufficiency of care workers, and with the problems of recruitment, with the bad conditions of the care workers. But it has nothing to do with the management of these public institutions, and the problems which concern also the families and the residents are not problems related to the management of the public residential care homes. Whereas these private institutions, of course, it's the question of management, and profit, because the organization is made to make profit and not to support and care for the residents and the person which are in the care homes. And of course, all this creates a lot of confusion for the population concerning the residential care sector. So this is why the government really took very seriously what happened with the publication of this book and the pointing out this scandal, and really pointed out the problem and really took immediately measures concerning the inspection and concerning the standard of the quality which must be in the institution. But this issue of standard concerns crosses, I think, different problems with this problem which concern really private care homes, and on the other hand, the residential care homes in general, with the problem of the recruitment which is insufficient, and the salary which is insufficient, and the recognition of the social care workers which is insufficient.
It's a very interesting comment in the chat about the role of guidance in the UK to increase standards around infection prevention and control. We're at time. I'll hand over to Adelina because I think you're going to wrap up. But just a huge thank you from me, because it's been such an interesting and useful discussion, and it's been a pleasure to work with you.
Yes,
Camille, thank you very much for your investment and involvement in this research. It was a pleasure for me.
Yes, thank you very much. We will be writing all of these up, and we will be sharing some of the findings, and we will be then, we have a next step coming, which is also what it is that we can learn from this, that will translate into lessons that can be useful in the English context as well. So this is not the end of this discussion. Thank you very much for your fantastic insights into what is happening in France and where you're going. And thanks, Camille, as well, for leading an excellent case study. And yeah, so we will be sharing the videos, and keep an eye. We will be sharing things through LTC COVID. And yeah, thanks a lot.
Very much. And
Thank you so much.
Bye.
Bye-bye.